So ASD. So we have discussed in our both offline and online class by our next tutorials. The ASD, once you think of an ASD, the most commonest be ostium secundum and the next will be ostium primum. So in ostium secundum ASD, we haven't discussed about any mitral pathologies, but in ostium primum defect, yes, we have discussed. So how we have discussed? The ostium primum ASD associated abnormalities like the mitral valve cleft leading to mitral regurgitation. It is given typically in your recent Bailey. And in Sabiston, the new edition Sabiston, it has been clearly mentioned the AV canal defect or AV septal defects are a complex constellation of cardiac lesions involving deficiency of the atrial septum, ventricular septum, and AV valves. So it is associated with ostium primum defect. And in Schwartz also, it has been clearly given that ostium primum ASD is associated with cleft mitral valve, in turn producing the mitral regurgitation. So it has been discussed plenty of times in our classes, and the right answer is ostium primum defect. As you all know, this is the typical area of endocardial cushion defect. This is also called as AV canal defect or AV septal defect. So any structures that has been formed in this region will be defective. And say in a case of a partial AV canal defect, there will be only ostium primum ASD and no VSD. And if we say it has an intermediate defect, means there will be a defect in the atrial septum and a defect in the ventricular septum. When to say it has a complete AV canal defect? If there is a complete structural deformity at this endocardial cushion level that comprises the atrial septal defect, ventricular septal defect, and the AV canal defect. This constitute the complete AV canal defect. Okay. So among the options, the right answer being the ostium primum ASD, because there is a clear-cut evidence in the classification that it will be associated with mitral cleft, and that may lead to mitral regurgitation. So again, this diagram which I used to show in our classes, the typical area of the endocardial cushion defect, which leads to ASD, ostium primum, VSD, and the mitral cleft, which in turn leads to mitral regurgitation. Then we can move on to the next question. And this is again a scenario-based question. During surgical repair of an ASD, the surgeon identifies the septal leaflet of the tricuspid valve and the ostium of the coronary sinus, which together form two boundaries of an anatomical triangle of Koch. While searching for the third boundary, the surgeon points to a ridge-like structure in the right atrium. Which of the following represents the contents of this triangle and the ridge-like structure forming its boundary? This is a bit tricky because we have discussed plenty of times that the triangle of Koch, its boundaries, and the content of the triangle of Koch. So by reading the question, it may take a few seconds, at least a minute, but don't look after the answer because it may be confusing. Okay, so once reading the question, just to think what they are asking. They are asking the content and one of the boundary. As you all know, what is the boundaries forming the triangle of Koch. So just write in your rough book in your examination and keep that and write that, and you have to assess what is the content. So this will be clearly giving an idea of answering this question. And you know, as you all know, the content of triangle of Koch is AV node. And what is the confusing picture is the crista terminalis, because the right atrium, this is one of the important structure in the right atrium. So as we all read in our classes that the boundary, one of the important boundary will be tendon of Teodoro. So the right option is AV node and tendon of Teodoro. So likewise, just you read the questions clearly and write it down and what they are asking, just to think and recall about the things what you have learned from our classes. Then you can straight away, you can look for the answers that has been read, because straight away don't read all the options. Definitely it will be confusing during examination. So this is this is the tricuspid valve, septal leaflet, the coronary sinus, and they are asking this boundary. This is tendon of Teodoro. This is the atrial septal defect. This is ostium secundum ASD. Clear? So AV node in the triangle of Koch. As you know, it is located at the apex of the triangle of Koch, The boundaries will be septal leaflet tricuspid valve, coronary sinus, and tendon of Todaro. So this septal leaflet, the coronary sinus again here. This is tendon of Todaro. You can nicely appreciate the AV node here. Okay. And next question. A 3-month-old infant is brought with poor feeding, failure to thrive, tachypnea, and recurrent respiratory infections. On cardiac auscultations, a continuous missionary murmur is heard best at the left infraclavicular region, suggestive of PDA. Okay, this is the clear-cut scenario given. The question is, which of the following conditions has a murmur most similar to that heard in PDA? So this is the question. So the continuous murmur, what are all the conditions that may be causing continuous murmur, you should know. And this is one of the basic question. This is not given clearly in any of your textbook like Bailey, Schwartz, or Sabiston. It has been given here and there. But it is the important thing, but you have to recollect what are all the conditions that may be causing a continuous murmur. So among the options given, so what could be the right answer? So here, the right option B, coronary AV fistula. Fistula, it is the right answer. A connection between a coronary artery and a venous structure such as the coronary sinus, vena cava, or the pulmonary artery. And most commonly on the right-sided structures, there will be the common communication between the coronary artery and the venous structure that leads to coronary AV fistula, and that presents as a continuous murmur. Always a continuous murmur occurs when there is persistent pressure gradient between two chambers or vessels throughout systole and diastole. That is very important. So in this angiogram picture, you can able to appreciate the fistulous connection. This fistula can be easily appreciated by doing coronary angiogram. Here you can appreciate the fistulous connection from the coronary artery into the pulmonary artery, and here from the coronary artery into the coronary sinus. So the answer is coronary AV fistula. And for those aspirants who are appearing for next year, so kindly note an important point. The coronary AV fistula is more common on the right-sided structures like the coronary sinus, vena cava, and the pulmonary artery. Again, this image will be clearly showing fistulous communication between the coronaries and the remaining structures. And what the point I like you people to follow is coronary AV fistula is coronary artery and a venous structure communication. What is coronary cameral fistula? So again, it is for the benefit of interest of the exam goers for the upcoming years. The coronary cameral fistula is nothing but the coronary artery connects directly to one of the 4 cardiac chambers. Okay, so kindly make a note of this image. So a question may be asked if question paper setter more interested about the coronary fistula, and you have to appreciate the coronary cameral fistula. It is nothing but the coronary artery connects directly to one of the cardiac chambers, and that too more commonly along the right-sided chamber. So you should also know the causes of continuous murmur. The first and foremost being the classic PDA, missionary murmur, followed by aorta pulmonary window. Okay, so that causes the continuous murmur. Then coronary AV fistula, as has been asked in our question, and the ruptured sinus of Valsalva, popularly called as RSOV. So this also tend to cause the continuous murmur. So clear? So next we can move on to the massive hemoptysis is least likely seen in which of the following? So the options given were mitral stenosis, mitral regurgitation, tuberculosis, so bronchiectasis. Coming to the massive hemoptysis, so you all know it may be due to tuberculosis cavity or aneurysmal rupture into the cavity, most probably due to the Rasmussen's following TB infection. And the bronchiectasis may also tend to cause a massive hemoptysis. And the remaining options left were mitral stenosis and mitral regurgitation. So again, this is a repeat question, has been discussed in our classes, and the table has been given in Schwartz clearly. Non-thoracic etiological factor causing a massive hemoptysis is mitral stenosis. Okay, so massive hemoptysis is least likely. So the answer is mitral regurgitation, and one of the non-thoracic etiological factor causing massive hemoptysis is mitral stenosis. So in this question, which is least likely, okay, the option is mitral regurgitation. Here it is clearly given in Schwartz. So what is a massive hemoptysis? Is defined as coughing out more than half liter to 600 ml of blood in 24 hours, or coughing out more than 100 ml of blood every hour. So this is a clear-cut definition for a massive hemoptysis, and this is again taken from Schwartz. You can able to appreciate the pulmonary causes, thoracic causes. So there are plenty of causes causing hemoptysis, that is massive hemoptysis. And if you look at the extra pulmonary causes, the congestive cardiac failure, coagulopathy, mitral stenosis, medications. So mitral stenosis is one of the important factor in producing massive hemoptysis, and it is not mitral regurgitation. Okay. So next question, and this image has been taken directly from your Bailey. A 45-year-old woman with bilateral pheochromocytomas presents with progressive dyspnea, episodic syncope on standing, and constitutional symptoms such as low-grade fever and weight loss. On auscultation, a mid-diastolic murmur is heard that varies with body position. Again, this is one of the important clue. The echocardiography reveals the findings shown above here. So what is your most likely diagnosis? So again, in this scenario, the patient had pheochromocytomas as adrenal tumor, right? Again, the patient is having a typical mid-diastolic murmur that varies in body position. So it could be a space-occupying lesion in the atrium level. So echocardiography clearly shown this is the left atrium, and you can appreciate a huge space-occupying lesion in the left atrium. So what it could be? The options given were left atrial mural thrombus, left atrial myoma, left atrial myxoma, mitral valve vegetation. So it could be any of the options, but with the hint what they have given in your question, the patient is having bilateral pheochromocytoma. Can you people able to recall what we have learned in our classes? So we have discussed about the Carney's complex, right? So the correct answer is left atrial myxoma. In 5% of cases, myxomas will be there in the Carney complex. The Carney complex is nothing but it consists of adrenal tumors, most commonly adrenal paraganglioma or pheochromocytoma, schwannoma, along with cardiac myxomas. So it is one of the triad in Carney complex. The treatment is surgical excision. Okay. And next question, a middle-aged man presents with acute chest pain and dyspnea. He is found to have a large pericardial effusion, for which pericardiocentesis was performed twice, but the effusion was reaccumulated each time during the same admission. ECG showing diffuse ST elevation. So what will be the most appropriate management? So they have given the complete history and the current scenario. So what could be the most appropriate management? So what you learn from the question, it is nothing but the recurrent pericardial effusion in spite of pericardiocentesis. Then during the admission, the patient is having diffuse ST elevation. So what does it mean? So it is a clear-cut case of pericarditis. Okay, pericarditis and the recurrent pericardial effusion. So since it is a recurrent, repeat pericardiocentesis alone won't be helpful. The other option you can able to appreciate is a pericardial window. Yes, there is a possibility. And thrombolysis only with ECG ST elevation, you people cannot come to the conclusion that patient is having MI unless it has been clearly given in the question as MI. You should not take it as an MI because this diffuse ST elevation can be a typical feature of a acute pericarditis. I will be showing a picture so you people won't forget. then emergency CABG and open drainage, and this such a major procedure is not needed in this acute setting. Okay, so the viable option among the thing given below is a subxiphoid pericardial window. So that is the answer. And it is a surgical intervention is required to manage a recurrent disease. It is a typical case of acute pericarditis. It may be due to an acute MI, but in question it has been not given as acute MI. So okay, and this is again the recall session. This question has been purely based on you people. Okay, so I also don't know what that has been exactly asked in the question. And with this question, I can able to conclusion that it is due to acute pericarditis. Suppose if it is due to acute MI means, again the pericarditis is a component of Dressler syndrome. So in those conditions, again the option will be the pericardial window, and if an option given as pericardial window with PCI, and you have to choose that option, because in acute MI by doing a pericardial window for a recurrent pericardial effusion is not sufficient, and you have to address the primary issue, that is coronary lesion, that you have to do a PCI. But if in the question it has been given as MI, you have to search for the options of for a pericardial window along with PCI. Okay, if there is not given in the question that there is no MI, only ST elevation, and the correct option will be subxiphoid pericardial window. Clear? So what are all the typical features? The pain, retrosternal chest pain. On auscultation, you will be hearing a pericardial rub. In EC, there will be diffuse ST elevation and PR depression, a pericardial effusion, like in our case. With all points are given in Schwartz, right, in 840 pages. And this ECG will be clearly showing how it appears, the ST elevation, how it appears in pericarditis, and how it appears in MI. So this is the ST elevation. You can able to appreciate with a smiley pattern. So this is pericarditis. It is not pathological. You can easily manage by doing pericardiocentesis for an effusion, or you can easily manage it with NSAIDs for a pericarditis. But you can see it is a dangerous sign. This is again ST elevation. You can able to see the convexity pattern. Okay, so this is a very bad sign, and this clearly depicts MI. And I hope this ECG will be very helpful to differentiate acute pericarditis and acute MI. Okay, so we can move on to the next question. A 7-year-old boy was operated for aortic valve repair at 3 years of age, and now presents with aortic regurgitation secondary to failure of valve repair. Okay, so true statement. Again, there has been plenty of discussion in the WhatsApp group by RRM Next and DocTutorials, and everyone convinced that 2 times the single option has been repeated. In the current era, replacement of bioprosthetic valve is rarely done. Again, it has been repeated. And third option was mechanical valve is preferred in older children as there is less growth potential. The last option is continue with the redo valve repair, that is Ross procedure. So what could be the true statement? The true statement is Ross procedure. So we have to do redo valve repair. Okay, so in a child, we should do valve repair. We will be discussing in the next slides, and I like to tell what is the Ross procedure. The Ross procedure is nothing but the pulmonary autograft aortic root replacement. Okay, this is the definition of the Ross procedure. You can able to appreciate the translocation of the pulmonary valve, right? Translocation of the pulmonary valve to the aortic position with subsequent replacement of the pulmonary valve with a homograft or a heterograft valve conduit. This is the typical of a Ross procedure. And again, this diagram, you can able to appreciate the diseased aortic valve has been removed, and the patient own pulmonary valve has been relocated to the aortic position, and the pulmonary area will be replaced either with a homograft or a heterograft. This is the Ross procedure. So why Ross procedure in children? Why aortic repair in children? Because there is a potential for somatic body growth, and we should avoid anticoagulation in children, right? And we should give a possibility of extended durability with the procedure what we are going to do. And why not prosthetic valve replacement in children? The prosthetic valves are fixed in size. Okay, it won't grow with child. Child's heart and annulus actually grow, and so we should avoid prosthetic valve. And this prosthetic valve can lead to patient process mismatch in future. When the child grows, the valve you are placing appears to be a small, and there will be a processes patient mismatch. And anticoagulant risk will be there in children, and bioprosthetic valve degenerate rapidly in children. Okay, so again, this is another contraindication in children, pediatric age. So the best option will be the aortic repair, redo aortic repair. That is the Ross procedure. Okay. Next question, again related to the valve. A 65-year-old male who underwent aortic valve replacement 13 years ago now presents with symptoms. Echocardiography shows aortic regurgitation with pulmonary hypertension. What is the most appropriate management now? So, an elderly male underwent AVR 13 years ago. Okay, so now presents with symptoms of aortic regurgitation. Again, this has been discussed extensively on the group. The options given were Ross procedure, TAVI, aortic valve repair, surgical AVR. So what is the appropriate management now? The answer is surgical AVR. Why? Because in this question, he was a 65-year-old, elderly, accepted, underwent AVR when he was 52, right? 13 years back. So at the age of 52, definitely he could have went for a mechanical valve. In the question, it is not given as a bioprosthetic or a mechanical valve. So we can assume the patient could have gone for a mechanical valve replacement. Patient now presented with aortic regurgitation. So the valve has been, maybe the patient may have degeneration or paravalvular leak causing a aortic regurgitation. So pertaining this situation, the patient is a good candidate for a redo surgical AVR. Okay. So, and you should learn, that has been discussed in our classes. What are the complications of a prosthetic mechanical valve? There may be a structural valve failure in the long term. There may be a paravalvular leak, thrombosis and thromboembolism, and there is a possibility of prosthetical endocarditis causing regurgitation. And again, this has been given and discussed elaborately in your latest edition, Shabistan 22nd edition. And there is a concept called valve in valve TAVR. So what is that? Because this is very helpful situation. Suppose a patient, an elderly patient, is 70 years, underwent a bioprosthetic valve, and is coming again at 80 years of age for with the symptoms of regurgitation. So in such conditions, elderly individual, 80 years, the surgical AVR is having its own risk. So in such condition, definitely we can go for a TAVI. It's a TAVI or TAVR. All are same only. So we can put a TAVI valve into the already placed bioprosthetic valve. Okay. And again, indications for symptomatic failed surgical bioprosthetic valve patients in high risk group. What are the disadvantage of valve in valve TAVR? It is given on your new substant. There is increased risk of coronary obstruction, and there is a possibility of increased in residual gradient across the valve. Okay. So next question. A 45-year-old male with posterior wall MI 3 days back was admitted, and during ward rounds, he deteriorated suddenly. Echo showed LV aneurysm arising from the posterior wall, which is narrow-mouthed and showing communication with LV cavity. Okay, so what is a true statement? Again, scenario-based, echo-based. So what is a true statement? Among the options, so read all the options, and it is LV aneurysms or true aneurysms, no risk of rupture. LV aneurysms are false aneurysms and need urgent surgical repair. Narrow-mouthed posterior aneurysms need not be repaired. LV aneurysms are pseudoaneurysms and do not need repair. So what could be the right answer? So the right answer is, it is a clear-cut case of LV aneurysm. It is a complication of MI. Okay. So what could be the right answer? The right answer is B. LV aneurysms are false aneurysms and need urgent surgical repair due to risk of rupture. Okay. It is one of the complication of MI. And the definitive procedure for this LV aneurysm will be surgical ventricular restoration or DOR procedure. So, and we have to excise the aneurysmal portion, and we have to find a healthy portion, and we have to repair, and we have to maintain the LV geometry, and we have to do a repair of the proper ventricle. So that this is the typical DOR procedure, and this will be the appearance of the DOR procedure, because we will be tackling the cavity, LV cavity. We will be excising the aneurysm. We will be placing a thick PTFE patch, and we will be repairing like this. So this is called as DOR procedure, or surgical ventricular restoration will be performed for LV aneurysm. So among the complications of MI like VSR, ischemic MR, free wall rupture, the ventricular aneurysm typically develops 2 to 7 days after MI, and interestingly, 2/3 are asymptomatic. But in our question, the patient collapsed during the ward round. So, and generally speaking, aneurysms of the ventricle are asymptomatic. Okay. And this is associated with transmural MI that causes necrosis of the ventricular wall. Yes, ventricular aneurysm. Okay. So next question, thymoma, about thymoma. Thymoma involving pericardium and great vessels. So what is the Masoko stage? As you all know, Masoko staging is for thymoma. So in this question, thymoma involving the pericardium and great vessels. So what could be the right staging? The answer is stage 3. Again, clearly given in Schwartz. Stage 3 is gross invasion into the pericardium, great vessels, or the lung. The Masoko staging for thymoma. Generally, thymoma are considered to be a benign, but the invasive nature of thymoma should not be forgotten, because even though it is said to be a benign, the invasive thymoma is having a malignant potential. Okay, stage 1, it won't breach the capsule. Stage 2, it breaches the capsule and into the surrounding hairy tissue or mediastinal pleura. Stage 3, it again, it has invasion potential, invade the pericardium, great vessels, or the lungs. Stage 4A, there will be dissemination into the pleural precordial cavity. Stage 4B, even though it is invasive thymoma, there is a tendency of a malignant potential in it. There may be a lymphogenous or hematogenous metastasis. And again, you have to note the histology subtypes given in your news assistant. And type A, for the benefit of exam goers, type A is most indolent and type B3 is most aggressive. Okay. So 5 years back, a question has been asked from the histology, from the lung pathological benign lesion. So you should also give importance to the histology subtypes of the thymomas. Next, the peak incidence of thymoma is in the 3rd to 5th decades of life. And another point you should note, even though the children have thymic enlargement or thymus related allergic conditions, the thymoma is rare in children. Okay, again, MCQ. Syndrome, systemic syndrome caused by immunological mechanisms due to thymoma. The commonest being myasthenia gravis, pure red cell aplasia, hypogammaglobulinemia, thymoma associated multi-organ autoimmunity, SLE, Cushing syndrome, SIADH. So again, this slide for the benefit of exam goers. So kindly make a note of it, guys. Again, very MCQ point of view, 10 to 15% of patients with myasthenia gravis found to have a thymoma. And another percentage, 40% of patients with thymoma have myasthenia or circulating antibodies to acetylcholine receptor. Okay, so kindly make a note of it also. And resolution of myasthenia symptoms in response to thymectomy. If you see means thymoma with myasthenia, we can expect a 25% of resolution of symptoms. But myasthenia without thymoma, right? Myasthenia without thymoma, if you do a thymectomy means there will be a 50% complete remission and 90% improves. So on a patient with myasthenia gravis, if you do a thymectomy, even though patient is not having a thymoma, the symptom will regress. But once the patient have thymoma along with myasthenia, the improvement of our complete remission of symptoms won't be there. It may be around 25% only. Okay, surgical approach. So how to approach the thymoma? It may be by VATS, median sternotomy with hemiclamshell incision. So these are all the types of surgical approaches for a thymoma. So how to treat a thymoma? Stage 1, straightforward thymectomy. Stage 2, since it breaches the capsule, we have to go with mediastinal radiation after thymectomy. For stage 3, because of invasive nature, we have to remove all the involved structures like pericardium, even adjacent other lung, phrenic nerve, SVC, or innominate vessels, and followed by reconstruction of those vessels along with postoperative RP. And stage 4, surgically, we can do a tumor debulking after a chemo RP. So these are all the approach for thymectomy according to the Masoko staging. And I hope it will be very helpful for the exam goers too. Next question. A patient presented with anterior mediastinal mass with chest X-ray showing elevated left hemidiaphragm and CT shows pleural involvement. So what is the most appropriate management? So anterior mediastinal mass, chest X-ray showing left hemidiaphragm elevation. So it could be due to a phrenic nerve palsy. So what can we do? The options given were like this. So according to me, the right answer is a radical en bloc dissection of mass along with phrenic nerve and pleura, and assuming the most common anteromediastinal mass being a thymoma. So thymoma, invasive thymoma, we have to do aggressively because surgical cure is very much we can expect from a thymectomy for a thymoma. So this clinical scenario, invasion of adjacent structures, it is again stage 3 thymoma. So we can definitely remove the involved surrounding structures along with the thymoma. We can postoperatively give radiotherapy after a thymectomy. And next question. A 40-year-old man presents with petus carinatum causing cosmetic concern and exertional discomfort. After evaluation, the surgical team plans definitive operative correction. Which of the following is the most appropriate surgical procedure for this patient? So, petus carinatum surgery. So, again, this has been discussed elaborately in our classes. So, what could be the answer? The answer is modified Ravitch procedure. So, modified Ravitch procedure is the right option. And these are all the different anomalies of the chest wall. The most commonest being excavatum, and the question that has been asked here is petus carinatum. So what to do? In petus carinatum, there are two types, and which is the most common again for the exam goers. The first type being chondrogladiolar prominence, the second type being chondromanubrial prominence. The most commonest being chondrogladiolar, and this chondromanubrial is popularly called as outer pigeon breast. Okay. So what is the treatment? For a flexible chest wall, corrective bracing. Okay. And for those with the complex deformities and inflexible chest walls, we have to do a surgical repair. Preferably, that should be performed at the end of pubertal growth spurt. Okay, it is given in your recent edition Sabiston 2. It is the modified Ravitch procedure. It involves the resection of abnormal costal cartilages while preserving the perichondrium. Okay, so from the pericardium only new bone, new cartilage grows. Then we have to do a sternal osteotomy. Then we have to reshape and reposition the sternum. This is the modified Ravitch procedure. And again, the important note is for pectus excavatum, even though the most common procedure was Nuss procedure, and there is also a role for modified Ravitch procedure. And for pectus carinatum, the only procedure surgically is modified Ravitch procedure. And next question, an elderly male presents with progressive dyspnea, chest pain, and cough. Evaluation reveals a left lung mass of 3.5 to 2 centimeter with enlargement of left paratracheal and subcarinal nodes with a single metastasis to brain. So what is the correct TNM stage? Okay, during our classes, I always emphasize students, so kindly concentrate on the staging system as any type of question can be asked. So this year again a question has been asked from the TNM staging with given all these scenarios. So the left lung mass, assuming it to be a lung malignancy of 3.5 centimeters. The patient is having the mediastinal group of lymph node enlargement. Okay. So again, the patient is also having the metastasis to brain. So once you know the TNM staging, it will be very, very helpful to answer any kind of questions. So for this question, the answer is T2N2 M1B. And how T2? That any tumor up to 5 centimeter classified under T2, and here ipsilateral mediastinal and subcarinal nodes comes under T2, and M1B, that is brain metastasis. Okay, so these are all the conditions you should apply in answering your question. And this, there are 1 to 14 station nodes are there. In this, station 2 to station 9 are mediastinal nodes, and station 10 to 14 are N1 group of nodes called hilar group of nodes, and this is supraclavicular nodes is called as metastasis, right? And we can move on to the next question. After pigtail insertion for a liver abscess, patient develops right lower chest pain, dyspnea, right hypochondrium pain. Image is given showing an air fluid level in the right side of the chest with atelectatic lung margin visible. So what's your diagnosis? So X-ray has been given and the patient known case of liver abscess. Okay, and suddenly patient developed symptoms and the X-ray shown like this. On the right side, you can able to appreciate air fluid level. So what could be the options given were pneumothorax, lung abscess, aspergilloma, none of the above. Okay. So liver abscess, possibly it could be ruptured into the thoracic cavity. With the presence of air fluid level, you can straight away go for the option as pneumothorax. The right option is pneumothorax. A large subdiaphragmatic abscess can cause hepatopleural fistula. The possible explanation can be given as because of inflammation, the pressure necrosis, and erosion of diaphragm. So all these three factors contributing to the development of hepatopleural fistula and the pneumothorax. Okay. A 50-year-old male presents with high-grade fever, pleuritic chest pain, shortness of breath, weight loss, and copious foul-smelling putrid sputum. There was leukocytosis, and chest X-ray has been shown like this. So what is your most likely diagnosis? So in this chest X-ray, what you can able to appreciate, so along the lung parenchyma, you can able to appreciate air fluid level in the lung parenchyma. Okay, so what are the options? Lung abscess, carcinoma lung, TB, aspergillosis. So among the options, the best option being lung abscess. An air fluid level observed within the abscess indicates communication with the bronchus. And you have to again note, most abscess resolve with appropriate antibiotic therapy and postural drainage. What is the DD of a lung abscess? It can be a malignancy, not all the malignancy. Specifically, a squamous cell carcinoma can present with a cavity, right? And it may be a loculated or interlobar empyema, infected lung cyst or bullae, TB, TB cavity with fluid level infected cavity, the bronchiectasis, fungal infection, and vaginous granulomatosis like conditions can also consider as a DD of a lung abscess. Next question. A patient with an apical lung carcinoma present with ptosis, meiosis, anhidrosis, and ophthalmos, so which are typical of Pancoast syndrome, with the Horner syndrome, with the radical arm pain. So which spinal nerve root levels are most likely involved? Okay, so Horner syndrome along with radical arm pain. So it shows the Pancoast syndrome. And what are the nerve roots involved? Again, repeat question from our classes. The answer is C8T1. Okay, the brachial nerve root involvement C8T1 will cause the radicular arm pain. So what is a Pancoast syndrome? Pancoast syndrome involves the Horner syndrome because involvement of stellate ganglion, then apical chest wall and shoulder pain, and radicular arm pain because of the brachial nerve root C8 and T1. Okay. Question. A patient known with carcinoma lung, diagnosed with carcinoma lung, present with deep aching pain over right thigh. An X-ray of the right femur shows the abnormality demonstrated above. So in this picture, like, what does this radiological finding most likely denote? This has been taken from your textbook. So many of you could have gone through this diagram. So what could be the likely possibility of this arrows has been given? So what it could be due to? The options given were a newborn formation due to periostitis, osteolytic metastasis, osteoblastic skeletal metastasis, pathological fracture. So the answer is newborn formation due to periostitis. It is given directly taken from your Schwartz. The newborn formation is a characteristic of hypertrophic pulmonary osteoarthropathy in a malignancy. Okay. So carcinoma lung, again the malignant condition, it leads to newborn formation. It is a characteristic feature of hypertrophic pulmonary osteoarthropathy. So what are the key features? Painful clubbing of fingers and toes, periostitis with newborn formation involving long bones, right? A classic Parenwest syndrome, most commonly associated with lung malignancies. Lung malignancies are more notorious to cause paraneoplastic syndromes. Okay. A 40-year-old male presents with headache, nausea, vomiting, lethargy, and mild confusion. Okay. There is no history of diuretic use or renal disease. Laboratory evaluation shows serum sodium, that is 128, hyponatremia is there, which is the most common lung cancer associated with this condition. So every year, a question will be asked from the paraneoplastic syndrome, and again this year. So last year, a question came from hypokalemia, I guess, and this year hyponatremia. So which is the most common lung cancer causing a hyponatremia-like condition with symptoms like this? The options given were adenocarcinoma, squamous cell, large cell, small cell. So what could be the answer? It is small cell carcinoma. And hyponatremia, typically it causes confusion, lethargy, and possibly seizures. A small cell lung carcinoma causes hyponatremia due to SIADH secretion and also due to ectopic secretion of atrial natriuretic peptide. So these two are the acceptable reason for a hyponatremia on a small cell carcinoma lung. Okay. Okay. Small cell carcinomas are associated with, again, for example, is Eaton-Lambert syndrome, SIADH, as typically causes hyponatremia, and ACTH-like molecule, as it may end up in hypokalemia or hyperglycemia. That has been asked in the previous years. Okay. What about squamous cell carcinoma? typically associated with hypercalcemia. Okay. So next question. The prolonged intubation was done for 30 days on a middle-aged male 1 year back. Now he presents with stridor and dyspnea. So likely diagnosis and treatment. The options given were tracheal stenosis and resection anastomosis, tracheal stenosis and stenting, tracheomalacia and stenting, tracheomalacia and resection anastomosis. So it is a clear-cut case of a tracheal stenosis, and for a tracheal stenosis, tracheal reconstruction is the best possible treatment to be done. So the answer is A. The stridor and dyspnea in tracheal stenosis appear when the lumen is obliterated by more than 50%. Okay, again, important point. The standard treatment for symptomatic patients consists of resection of the pathological segment of trachea with end-to-end anastomosis, that is called as tracheal reconstruction. So this is the picture that has been taken from your Savistron, right? Latest Savistron. So this is the stenotic segment. Usually it can be approached at the neck level. If it is at a lower level, means you can do a small split of the manubrium and you can resect the stenos segment, and we have to continue ventilation by putting the ET tube distally, and we have to take sutures, and after completion of sutures we have to pull the ET tube from above and we have to remove this ET tube. So likewise full tracheal reconstruction will be completed. So that's all. So thank you for you people for having this recall session, because with all your great effort, I can able to collect all the questions, and it is my duty to put correct options, correct answer for such question. And coming to this year, I understand it may be time consuming during examination. So there may be a brain fade moments during the exams by looking at the options. So my suggestion was, have a clear mind and just recollect what all the points we have learned from our classes, and just keep those as a platform, as a basic. Read the question clearly and think and come to the conclusion about the answer, then go for the options. So that is the way to answer. And I hope most of you people have rocked in this year, and all the very best. And kindly let me know after your result, and all the very best, guys. And for the exam goers for the upcoming years, and I hope this recall session will be useful for you all. Thank you so much for your listening.